Can you talk just about different tests? Because you even say be an advocate for more testing that's just
Right.
your regular panel. Can you talk about that?
There are some add-ons and extras that probably are going to be super helpful to you. And maybe insurance won't cover it, but if you have symptoms, they might. So make sure you discuss these with your doctor and ask for these tests. So one of them is like a hemoglobin A1C, which is a look back over the last 6 weeks of where your blood sugar has been. Most of us get tested for that. Okay. Then there's the HOMA-IR score. This is a measure of insulin resistance, and it's based off of a calculation based off of a fasting glucose, which most of us get. And all they have to do is add a fasting insulin level. And then you can go to an online calculator and calculate what your score is. If it's 1 or less, then the chances that you have insulin resistance are very low. If it's 1 to like 2, you're probably in early pre-diabetes and you have insulin resistance, even if it's controlled with diet. You know that you're at risk, so you really have to focus on your diet. And above 2, 2.5, you are severely insulin resistant. And you need to, this is a big red flag warning sign. We are moving towards diabetes quickly unless you make those changes to try to reverse the process. I am insulin resistant, very insulin resistant, which thank God with hormone therapy and diet, I can control.
And that is something that also can happen as you're going through menopause.
Right. So insulin resistance rises with the loss of estrogen, an independent risk factor, and nothing to do with aging.
Yeah.
It goes up with aging too, but you take 2 50-year-old women, one who's fully menopausal, one who's not, she's going to have a 3 times higher rate of insulin resistance than a non-menopausal patient. Make a problem visit for menopause discussion separate than your well woman exam. Okay. There's not enough time to get it done or to do it justice. Your best bet, go in with your family history loaded, go in knowing what you want to discuss. Go in, make the call before. Is this doctor going to discuss my options of hormone therapy with me? If they say no, he doesn't do that or she doesn't do that, do not make that appointment.
One of the things that I found was just so refreshing, relieving to have in the book was the role of estrogen and how it plays such a big role in women's lives. Can you talk about you can't probably go into all the benefits, you've got to read the book, but some of the benefits of estrogen in our body?
So estrogen in its natural form being pumped out of our ovaries day after day after day is incredibly protective. It is why women have less heart disease until menopause. It is why we have strong bones. It is why before menopause, it is why we have we have normal cholesterol before menopause. It is why we have normal insulin resistance for those of us, before menopause. It is why we don't have musculoskeletal syndrome until menopause. It is just a lubricant and anti-inflammatory hormone, so incredibly involved in multiple processes in our body, not just reproduction, which of course is an important phase, but it is literally linked to our cardiometabolic health. And when we naturally go through this transition and lose that estrogen, we see, independent of aging, those risks increase. And I think that was the key message in the book was, listen, estrogen is more than just a pretty hormone that lets you have babies. I mean, this is critical to us functioning at our optimum health as females.
When it comes to menopause hormone therapy, you break it down very clearly and you talk about synthetic versus bioidentical. And I thought that might be a good place to start. Can you explain the difference between synthetic hormones and bioidentical hormones?
So remember, all of the hormones that go into your body are made in the lab. So some are, the starting thing is plants, okay? And that usually leads to the bioidenticals. Others, the starting thing is chemicals but they all go through the same chemical processing. So coming out of a lab, so a lot of people think you just rub yams on yourself and that will be your hormone therapy. Stop buying yam cream. It does not work. There's no clinical evidence to support it. Yams are often the starting botanical but you got to put it in a lab, you got to add this chemical and do that and extract that and then in order to get the estradiol. Body identical has a synthetic process to get to it. Body identical means it is chemically identical at the end result to what your body made. Okay. And that's estradiol, estriol, which is the pregnancy hormone made in the placenta, and estrone, which is what is converted to in our fat cells from the periphery. But the most biologically active, safest, and most what your body is needing to stay healthy is estradiol. So that's my go-to formulation.
You were bringing up testosterone, how you prescribe testosterone. I take testosterone cream as well. And that is such an issue. You will have some doctors that won't prescribe it. Some doctors
Not trained.
Yes.
So there's I wasn't trained. I was scared of it for a long time, even early days in my menopause clinic, until Kelly Casperson was like, you need to prescribe testosterone. And so I started experimenting with it with my patients, and they're like, the best thing ever. I started it. Okay. I have low muscle mass. I mean, it's better. Okay. But I've genetically just don't have a lot of muscle. I've always been kind of, wimpy and thin limbed. And I know I've got to hang on to my muscle to stay healthy as I age. It's like critical. And so I'm doing the resistance training, eating the protein, taking the creatine. And Kelly's like, you should try some testosterone and see if that'll help with your gains. I was like, okay. I never thought I had a libido issue. It is absolutely tried, true, and tested for hypoactive sexual desire disorder, which is in the brain. Okay. For women, terrible thing that happens in menopause for the majority of us. I didn't have any problems. I thought, okay, everybody was happy at my house. No one complained.
You talk about the different hormones, and then you also talk about the people who can and shouldn't use hormones. And the big thing, the big scare was the breast cancer scare from the Women's Health Initiative. But then you also talk about that it's not necessarily a thing that you can't have hormones if you had cancer. Can you talk about those issues? Yeah.
So it's a very complicated, nuanced discussion. Now, certainly if you've had a stage 1 endometrial cancer, no increased risk of recurrence with hormone therapy. If you've had vulvar vaginal cancer, no increased risk with hormone therapy. If you've had cervical cancer, no increased risk post-treatment with hormone therapy. There's so much misconceptions. Breast cancer is a very complicated, nuanced discussion. Certainly, if you're in your treatment window, you are not a candidate. If you're on an anti-estrogen, you do not want to be taking estrogen unless it's vaginal. Vaginal estrogen is fine for every single human, no matter where she is in her life or what cancer she has. You can use vaginal estrogen. I'm talking about systemic estrogen therapy. But if you're past your breast cancer treatment, you're done. And now you're looking to the next 30 to 40 years, the most likely thing you're going to die of is heart disease. And if you've been on an anti-estrogen, that risk is accelerated because estrogen is protective against heart disease. So now begins the conversation, which is being denied to the majority of menopausal patients who are post-breast cancer treatment, is the nuanced conversation of would hormone therapy in whatever area be a good decision for you for your overall quality of life and your overall health, not just your risk of breast cancer. So you really need to find an informed. Now, family history of breast cancer, no problem. If you have a genetic risk, and we talk about the different genotypes that might be, again, nuanced conversation.